Hello, my name is Tate Davis, and I'm a researcher within the National Science Foundation Sustainability Research Network. I'm presenting an interdisciplinary research project between Georgia Tech's School of Environmental Engineering and School of City and Regional Planning, as well as the Division of Environmental Health at the University of Minnesota's School for Public Health. This project investigates demographic inequities in health outcomes and air pollution exposure in the Atlanta area and its relationship to urban infrastructure. The unequal distribution of environmental burdens among different demographic populations have been observed in a number of studies. Previous research suggests that minority populations with low SES typically tend to bear the brunt of these burdens. This increased burden can often translate into unfavorable health outcomes. While air quality has a significant impact on health outcomes, air quality and health outcomes may be impacted and mitigated by a built environment and urban infrastructure. In order to assess the influence of each factor, the study was conducted to characterize inequities in air pollution exposure and relevant health outcomes, and their relationship to urban infrastructure factors. Counting for spatial autocorrelation, data at the census-tract level was used to conduct a cross-sectional analysis on air quality, health outcomes, and urban infrastructure characteristics. The data analyzed in this study took into account novel data sets, which provide a finer scale resolution at the census-tract level or lower across all variables. This fine scale data is important in helping to characterize these relationships at a scale which has been previously unattainable. The scope of this study includes 4 municipalities in the Atlanta area: the City of Atlanta, Johns Creek, Roswell, and Sandy Springs, which vary in demographic composition and population density. Within these 4 municipalities, data was available at the census-tract level through the Center for Disease Control's 500 Cities project, published in the summer of 2016. This project used small area estimates to provide finer scale data for chronic asthma, chronic obstructive pulmonary disease, coronary heart disease, and stroke. These health outcomes were chosen for their established relationship to air quality. For this study, 2 air dispersion models, R-line and CMAC, were combined together as one into what is known now as the R-line CMAC fusion model, which is utilized in this study. This fusion model allows resolution at a 250 by 250 meter grid. Values were aggregated to the census-tract level to compare with health outcomes. Infrastructure variables included tree canopy, park access, and road density at the census-tract level. And finally, demographic data was available through the U.S. Census and included variables for age and race. These results display the averaged PM2.5 and NOx levels aggregated from the fusion model to the census-tract level. The scales accounts for EPA levels of attainment. It is visually suggested that the census tracts in the southern areas of the city of Atlanta have PM2.5 levels greater than the EPA yearly limit of 12 micrograms per meter squared, as well as the NOx levels, which exceed 54 micrograms per meter square per year. Spatial analysis for health outcomes seems to mimic this spatial relationship, as those same southern census tracts also show high prevalence of asthma, COPD, CHD, and stroke. When looking at the statistical models, these relationships are further supported. The crude analyses individually compared how pollution exposure and racial demographics relate to cardiovascular and respiratory diseases of interest. All models for PM2.5 showed that census tracts with higher exposure levels tend to have higher prevalence of cardiovascular and respiratory disease outcomes. All of these results were significant at a 95% level of confidence. The models for NOx also showed that higher exposure levels were associated with higher prevalence, but the results for COPD and CHD were not significant. The model using the binary indicator for having a predominantly black population showed that census tracts with a predominantly black population have greater prevalence. Across all adjusted models, the indicator variable for having predominantly black population had a significant positive association with higher prevalence of disease. Census tracts in this region with majority black populations are therefore more likely to have a greater prevalence of each of the 4 health outcomes. Our findings did show atypical results in that tracts with greater tree canopy cover or park access, adjusting for all other factors, are associated with greater prevalence of disease. The results from these models show that census tracts that have predominantly black populations are associated with greater levels of both PM2.5 and NOx. Furthermore, census tracts with greater amounts of tree cover were associated with increased levels of PM2.5. Our results supported that the existing health and air pollution inequities in the Atlanta area. This study supports that racial demographics had strongest association with prevalence on each of the 4 health outcomes and examined higher ambient levels of PM2.5 and NOx. The relationship of urban infrastructure as a contributing or mitigating factor to these outcomes is still to be determined. Due to the high correlation between these variables, causal relationships were difficult to characterize. Further work on the topic would aim to address the study's limitations and provide more insight into the etiologies and the inequities of air quality, health outcomes, and urban